Vic Gatto with Hellstorm. I have Todd Furniss on today. He is the CEO and managing partner at GTC Group. It's a Dallas-based private equity group. Todd is really thoughtful guy. He digs into policy at a deep, deep level. Great guest. I talked through everything with him from COVID-19, what the impact's going to be, to also long-term societal things that healthcare has to wrestle with these days. Todd is really intelligent, great guy who's done a ton of research. Please watch. Great show. Thanks a lot. I'm Vic Gatto. I have Todd Furniss here. He is the CEO and managing partner at GTC Group. Todd, thanks for doing this in such unprecedented times.
Thank you so much for having me. I'm looking forward to our conversation today.
Yeah, it should be fun. So, just for the audience, give a little your personal background. Talk about GTC and then what you've done in your career.
Sure. So GTC is an organization, a private equity firm that also does macroeconomic research. And we've been investors in a variety of different industries over time. I grew up as a lawyer first and in the technology world, then moved into operations and the strategy and acquisitions for a large publicly traded company called EDS under the leadership of a guy named Les Aberthal and Dick Brown after Mr. Pro left. But it's been a fascinating journey through a great deal of both domestic industries and foreign industries. So spent time in Asia, Australia, New Zealand, a lot of time in Europe, all over the United States, and in a variety of industries. But I've spent probably the most significant and focused time in the healthcare industry. After I left EDS, I went into consulting, and we advised 8 of the top 10 academic healthcare providers in the United States, and then worked a lot in doing everything from advising boards of directors and management teams of healthcare systems into writing about them in terms of macroeconomic research reports. And then lastly, doing restructuring work. So our last big undertaking was to restructure 5 physician-owned, especially surgical hospitals with 1,800 credentialed physicians, 1,200 employees in 5 different cities.
Yeah, getting 1,800 physicians to sort of be aligned and go in the same direction is challenging.
That's a story for another day, let me tell you.
Yeah. So give me a sense of the scale and scope of the GTC portfolio. How many investments? What's the size? What kind of industries are you in?
We've been traditionally focused on business services, healthcare, and financial services, and we're pivoting into a greater focus on healthcare right now because we see the opportunities emerging that are probably going to be once in a generation types of once in a generation opportunities, in part because of the things that, in fact, you've been talking about, really this nexus of government and healthcare, payment systems, and technology. Those are all going to drive big changes in our industry.
Yeah. I mean, obviously, I completely agree. So, and then give me an example of the type of deal you would do. An example portfolio company or the kind of stage and size of a deal.
So we try and like everybody, we try and adhere to some fundamental principles like positive cash flow and growing revenue and stable and predictable revenue or cash flows. In these kinds of times, of course, that throws everything into a little bit of a wrinkle. But typically, we like to do deals with, where we're looking at bite size of $75 to $100 million or more, and we're happy to partner with others and do what we think makes the most sense given the opportunity, as opposed to try and drive to really fixed dimensions of an investment. So many things are really under the covers, as you know, and if you don't really dig into it and do the diligence, it's hard to figure out what the answer is. So we try and come about it from a much better informed perspective, given that we have a lot of operational background in our team.
Yeah. Okay. Thank you. Appreciate that. So, as you know, we talked about it in the prep for this. This is called the Hellstorm. Last fall, I started around Thanksgiving. I started kicking around the idea that there was a storm coming to healthcare. I thought in 3 to 5 years or so, and wanted to explore that in these talks. of course, with COVID-19, the storm came much more quickly. And so the prep time or the time to get ready was much shorter than I thought. But my assertion is that the outbreak that we're in crisis with right now and trying to navigate through has really accelerated a lot of the trends that were already in place. And I just want to get your thoughts about that. So there's really 4 trends that we've been looking into in these discussions. The first is that there's a lot of new technology. I mean, telehealth is probably the most widely covered, but lots of technology that has been coming to healthcare, but now with COVID is coming like really quickly. So do you see that as well?
Yes, and I think what you correctly identified was that the impact of COVID on our society has hit us from a bunch of different dimensions simultaneously. So let me walk you through that real quickly. Yeah. So one of the big impediments that nobody talks about in telemedicine is the regulatory issue associated with licensing. So if you're a doctor sitting in Florida and you're trying to give counsel to a patient in California, under the current rules, you've got it before the COVID virus.
Pre-COVID, yeah, right.
Yeah, you had to be licensed in the state where the patient was. Well, now those licensing requirements have been relieved, and we've got at least a temporary respite from those things. And that's just one example, but there are all sorts of them that will continue to manifest. So as government eases regulation and states ease regulation, then that gives rise to opportunity for technology and for the markets really to work better as a single market. And I think that's going to definitely accelerate the trend in the application and implementation of technology in the field of healthcare.
Yeah, I mean, I completely agree. Another trend we've been looking at is what I call the rise of the consumer. Individuals trying to take control, operational and financial control over where their health care is going, where they're treated, what the treatment is. I think the days of just listening to the man in the white coat are gone. But there aren't a lot of tools, and there aren't brands, and so there needs to be a lot of things put in place for the consumer. And I think again, COVID is sort of accelerating that process.
Well, it is, and at the same time, there's more to be done there. And because you touched on a lot of topics in that one simple statement. So, for example, we talk a lot about things like the tools that would be available. Most people don't realize this, but in 49 of these 50 great states, the patients do not own their own data. Yeah. So only in New Hampshire does the patient own their own data.
Yeah, live free or die, baby. Live free or die.
Exactly. So the second problem we have is that even if you could ingest all the information, most physicians wouldn't know what to do with it, even if they could. It'd be a time-consuming, arduous practice to go through and digest all the information of the patient for their life. I take myself as an example. My general practitioner is great, and I talk to him, whenever I need to. But I had a total knee replacement last summer. He didn't have those files until I said, "Hey, why don't you have those files?" So his office had to reach out and grab the files. Well, I also had a bicycle accident last year, before I had the knee surgery, and I was in the trauma unit for 4 days. He didn't have those files either. But once he has those, then what does he do with them? So I think that the future will include AI to sort through all this, and cognitive reasoning platforms. So there's a big technology play that's on the horizon that hasn't yet manifested. But I think the other thing that we got to figure out is the payment mechanisms. So as we think through the individual consumer and what they are or are not able to do, a lot of this is going to be completely correlated to how they pay for it. So the use of and the advent of things like HSAs and FSAs, health savings accounts and flexible spending accounts, those things will be very helpful in providing mechanisms through which the patients can actually pay for their services in a tax-advantaged way. But more people need to learn about them, and we have to have better tools, and they have to be more flexible in how they're used.
Yeah, I agree. Then the last one I'll just mention is that I think I see market entry from non-traditional platforms. So, of course, it's always been hospitals and providers and payers, insurance companies. And I think it's pretty well documented. Amazon, Google, Apple, Walmart, they're all moving into this space before the outbreak. And I think that there's going to be more and more of that companies that understand technology and understand AI and understand sort of massive scale, while also knowing how to get the consumer engaged and sort of service the consumer. Do you see that as a trend as well?
I do, and I also see big explosions where the conflict occurs between regulation and technology. I think it's kind of inevitable because technology is always forward-thinking and innovative, and laws and regulations are always exactly the opposite. They're reactive. So, and I think that one of the things that will frustrate but will be resolved ultimately by technologists is that they don't typically understand the regulations that they're interfering with or that they're going to come across. And so, for example, as I was helping some folks think through the PPP issue and how do you get loan applications quickly submitted? Well, then that branched into how do you think about getting an application built that would suffice for other loan opportunities from the SBA and others. And then we said, well, if you package those loans and you're not a bank, are you sort of running into banking regulations?
Yeah, right.
Well, the same can be said on the other side with regard to healthcare information and HIPAA and the High Tech Act and all sorts of other things that are designed properly so to help avoid invasions of privacy. But Google already has a ton of personally identifiable information in their databases, and that cat's kind of already out of the bag. So how do you walk that back to some extent, either through regulation or for revised processes and tools and templates and technology?
Yeah. So I would say it's both ends, right? Like they're unlike consumer tech or social media or something, move fast and break things, the classic Facebook thing. It doesn't work when human health, it's someone's mom being operated on, right? And when it's my mom, I want to make sure that we have appropriate controls and guidelines and regulatory structure. The FDA and HHS and CMS are strong, and I think for good reason they're strong. Entrepreneurs are not just going to be run over regulations like they have in other industries. And yet we have to be flexible enough to change and sort of accommodate these forces.
Well, I think you're correct there. I think the issue is, and then there's kind of a fundamental moral or ethical question I don't think anybody has really surfaced and talked about in earnest, which is it moral to make money from healthcare?
Yeah.
What we're saying essentially is we're a capitalistic society and we have to encourage investment and activity in these things. And if we want the best and the brightest in the industry, then they have to be paid well. At the same time, on the other side of that equation, we're saying, hey, wait a minute, these people are down. They're not in an equal bargaining position. There's an asymmetry in knowledge and an asymmetry in the need for care and the obligation to provide care. How do you reconcile these things? These are big, big, tough moral questions that I don't think as a nation we've really gotten our hands around. Yeah. And when you talk about it in the context of your mom, like I would talk about it in the context of my mother or my daughter or my grandchild, it takes on a whole different patina, if you will, about how we really get our arms around this stuff.
Yeah. Yeah. And that's a good kind of segue into the next topic I wanted to discuss with you, which is, hospitals and even community hospitals are ground zero for the COVID treatment right now. As we talk, they're treating patients. And unfortunately, that is not very profitable work. And so assuming they get paid for the work, it's going to end up with those same hospitals being financially weaker after this, because the elective surgeries, the knees and hips and other things are much more profitable. And so you have an interesting moral, societal challenge where the very people that are sort of helping in this all hands on deck crisis are being weakened by that. And how do we reconcile that? What do you see coming out of that?
Well, I think you're absolutely right. Now, there are a couple of things underneath there where the federal government is actually reimbursing people who have reimbursing systems and caregivers who are treating COVID patients at a pretty significant rate. So $13,000 is the number I've been told if you've got a COVID patient, and $39,000 is the number I've been told if you have put somebody on a ventilator. those are pretty significant numbers. I think we're also seeing another issue, which is, on the one hand, you're not having the benefit of elective surgery. On the other hand, the outbreak in rural communities is not as bad as it frequently is in the urban areas. So New York City, for example, has produced about 45% of all the COVID deaths in the United States. I'm currently sitting in Riverside County, where there are fewer than 11 patients in Eisenhower Medical Center with COVID. So it's not an evenly distributed problem, and the nation has to handle each individual area differently and appropriately given the circumstances they're individually facing. Having said that, I think your point is broader, which is rural hospitals have been under siege for a while. We wrote a report on the economic drivers of consolidation in the healthcare industry after the ACA was passed, and predicted that this is going to happen. In my hometown of Dallas, 4 hospital systems comprise 98% of the market. So if you take out one of them, 3% of the hospital systems comprise 91% of the market. So you've got an oligopoly that's formed on the provider side, and you've got the same thing that's happened on the payer side. And that's not good for anybody. And one of the things that has come out of the COVID crisis that I hope people extrapolate into is this issue of concentration risk. We have concentration risk in our supply chain by virtue of so many things coming out of China, but we also have concentration risk in our delivery mechanisms with regard to the hospitals that we're now seeing. And so as rural hospitals and smaller hospitals, independent hospitals become more and more fragile, then we're going to have an increased concentration in our reliance on the larger hospital systems in each of the major metropolitan areas.
Yeah, so I think everyone is talking about in the supply chain, we need to move from absolute low cost optimization to a balance of low cost and resiliency. And I think you could say the same thing for our healthcare system, right? We need to reduce costs, certainly, it's very expensive, but we also need to make sure it's resilient enough to withstand changes.
Well, you point out 2 very important things there. First of all, capital is efficient, and it's always going to go to the lowest cost source of labor or expense in delivering the good or service that it's trying to deliver. And so I actually was very involved in helping companies think through how to move around white collar workforces after Y2K. So we helped at Everest Consulting, or Everest Group, when I was the COO there, we helped a lot of large companies move, call centers and back office functions into India, Vietnam, China, et cetera. And the issue of regulation comes into play here as well, because the cost of having employees in the United States is so much greater than the cost of these offshore locations. And so we can't just simply say, well, we're going to force labor back onshore. What we've got to do is we've got to figure out how to make the regulatory environment such that the total cost of employment people is competitive worldwide. So that affects not only labor laws, but also tax laws and the other.
Yeah, I mean, we need to design the incentives so that people naturally bring workers back. It's the most advantaged place to be.
Correct.
And we have great talent here. We need just to make sure we have the systems and infrastructure in place so that they're not so expensive.
But let me give you an example of how disconnected we are to some extent in some of those realities. We did a research report a few years ago that asked the question, what is the effect of the participation rate of the labor force? And we did an analysis of the value of entitlements. And we said, what does it cost if you get access to unemployment or welfare, as the case may be, utilities, rent subsidies, add it all up? And it came to a shocking number. And this is 5 years ago. The number is $27 an hour.
Yeah, if you take advantage of all the support structures.
Correct. So how is that ever going to be competitive with India or Vietnam or the Maldives or Mexico or Brazil, name that foreign jurisdiction? So we have to figure out how to create the right structure where it makes sense. And that's by structure, I mean labor laws, tax laws, compensation, benefits, et cetera. They all have to go together. And what I'm fearful of is that what's being lost in the conversation to some extent, although it was certainly in the conversation pre-COVID, is the issue of technology taking these jobs altogether. We worked with a cognitive reasoning platform company a while back where we had an investment, and they did a proof of concept that eliminated 6,500 jobs with no human intervention in the United States in one major metropolitan area. The reason management did not adopt and implement the technology was because they were fearful of the microeconomic impact of that.
Yeah. I mean, it was functional. It would have worked, in other words.
It did work.
They didn't like the PR. They didn't like the impact on the city. They didn't like the other non-financial aspects of it.
They were terrified of that. And so it was we calculated back of the envelope math, was $750 million in salary, wages, and benefits by themselves, saved into perpetuity. Now think about that for a second. Now, if you use the velocity of money argument, that's roughly 3x, you're talking about almost $2.5 billion worth of economic activity completely gone from that local economy.
Yeah, now they may have not wanted to jump in front of that train. I don't know if I blame them, but you definitely wouldn't hire new people. You wouldn't build the company that way again. You'd use this technology and build it much more low HR, more tech.
Right. Now think about it. What happens if you have an activist shareholder on your board? Right. The hedge fund guy or gal doesn't care. Right. They're completely indifferent to that issue. They're saying, look, this is all about shareholder value creation. I want you to whack the $750 million in expense right now. So I think we have to be careful. We have to be thoughtful about how we migrate from point A to point B and where we are in that evolution. And I know that there are lots of folks on the Hill who are very concerned about it. I know this is one of the things that keeps Ben Sass up at night, for example, who's a fantastic senator out of Nebraska. But a lot of people just are not putting the dots together, connecting the dots with regard to the issue of trying to force a non-market wage and what the implications might be in terms of technology adoption.
Yeah. Okay, so talk to me about timing of things. So to me, in healthcare, maybe in life, but certainly in healthcare, timing is everything, right? So you can be right, but if you're not on time, if you're too early, you as an investor you lose money or it doesn't work. And so I've been trying to think through. It's unprecedented times we're in. There's a crisis today. Right now, we're sort of fighting the outbreak, but we're sort of trending towards moving into recovery. So the next couple weeks to a month, I think we're going to shift to beginning to think about, we're already thinking about what can open, as we roll out, different openings around different states. I think we'll move into a recovery, and then eventually I've been calling it the new normal. We come back to normal. It's not the same normal as at the end of the year, but we're back at like a new state of normal. First of all, does that make sense to you? And what do you see as the timing of those stages?
I think the logic works, but I don't believe it's going to be serial in nature. And by that, what I mean is there's going to be a little bit of a bleed from one thing to another, one stage to another. They're going to overlap somewhat, and it's going to be.
It might even be like a retrenchment or go back to
cyclical activity. Yes. But I think that the recovery, while I hope desperately that it's going to be quick and rapid, I think that the folks who are saying that will be with certainty don't really understand the complexity of the issues at hand. So by way of example, I was on a call working with some folks in the world of sustainable development, and one of the guys was a restaurateur. And the restaurateur said that he had 20 restaurants, and he figured it was going to cost him around $300,000 per restaurant to reopen. Yeah. Because the employees he couldn't take the PPP loan because his employees had all left. He lost 1,400 employees. And they had gone, because the way it was structured, they got more money to be on unemployment than they did work. If he took the PPP loan, then it wouldn't be forgiven because he didn't have their employees. And then he's got to rehire and retrain the employees, but then he's also got to take all the furnishings out and sanitize his store. And then he's got to suffer increased costs associated with keeping the store open because he's got to sanitize every night. So then the question becomes, how can he possibly have those increased expenses and operate on such a, when the business is low margin already, how can you go from that into an environment where he's only able to use 25 to 50% capacity in the seating, right? So that's a problem. And then the question becomes, well, what happens if you go to things like, outdoor service and plastic utensils? Well, what happens if if there's a run on plastic utensils like we saw on paper towels?
Yeah.
Right? And so the ripple effects of this, I think, are still widely unknown. And they will probably never be known, but we got to figure out that level of detail to understand how things are going to recover. And I think, again, it's going to be industry by industry. I think what's also going to happen, having said all of that, is we're going to see what I think is going to be a slow reintroduction in terms of the human behavior. But I think what we're also going to see is a snapback. So people will wear masks for a while, and all of a sudden they say, screw this, I'm done with it. I'm going to go back to normalcy. And they're going to go to the restaurant on Friday night, or go to lunch on every day of the week, whatever they're going to do. But they're going to grow weary of the limitations. They're just going to be exhausted by it.
Yeah, so I mean, I think I agree with all of that. I think it's not going to be a snapback economic recovery. I think I've been using the word unprecedented. What that word means to me is that we haven't seen this before, right? We don't know what it means to open a 20-store restaurant. We don't know how that restaurateur will find the capital. We don't know how long it'll take to hire the people. We don't know if he can operate successfully, profitably, or not. And every one of those entrepreneurs are going to open one restaurant and experiment and try to learn, because there's no recipe. There's no, I'm using the recipe analogy. There's no game plan. There's no way to know, because we've never been through this before.
Well, and then think about the legal risk. What happens if somebody gets the virus? They went to the restaurant the night before.
Right, and whether they picked it up there or not is unknowable, right? Like, they could have easily gotten gas on the way home and got it at the gas station, but they will recall where they went to dinner more easily, and all of a sudden he's in a lawsuit.
Exactly. So I think it's a complex issue, and I think it's going to take some real experimentation. I think that there's a silver lining here, though, and this is something that most people aren't focused on. And I'm, as you would expect of me, wonky enough to go do this kind of homework. I looked at some New York City statistics the other day, and it said that in the over 9,500 deaths that were from confirmed coronavirus cases, 54 were not over 65 years old and did not have pre-existing conditions. In other words, the vast preponderance of those people who died,
almost everyone was.
Yeah. The vast preponderance of people who died had both old age and pre-existing conditions working against them. Now, there's one other thing I've written an op-ed piece about this, and it's very controversial, and it hasn't come out yet. I'm kind of surprised it hasn't. In 1910, a guy named Abraham Flexner wrote a report that completely changed the way that physicians were trained and educated and licensed across the United States. It closed down, as a result of the Flexner report, all but 2 medical schools for Black physicians and physicians of color. Today, Black physicians comprise 4% of the total physician community, despite the fact that Black Americans are 13% of the population here. Now, what was surprising about that was a follow-on study done by the Bureau of Economic Research, a snippet of which was published in the Washington Post in December, that said that older Black males were over 50% less likely to get invasive screenings for things like diabetes and cholesterol, or even to get a flu shot, if those tests or shots were administered by a white physician. So that means that we need more Black physicians, and we don't have the ability to ramp that up quickly. And if you look at one of the problems we have in COVID is more people of color are disproportionately dying from this, but also more people of color also are have these underlying conditions which make them more vulnerable. So the issue to me is not COVID, the issue is the underlying conditions, and we have to really attack that.
Yeah, so I completely agree. I think we're going to see a shift. As soon as we get through the crisis, we're going to see a shift towards more attention to public health, more investment in public health. And I would view public health as a means to try to affect pre-existing conditions, particularly in vulnerable populations, so that we try to help them be prepared, be a little bit more healthy, be slightly less vulnerable by taking care of diet, exercise, diabetes, cardiac conditions, hypertension, all the various classic chronic problems, but also poverty and not access to enough food and childcare and the whole suite of things. I think we all now realize are important to build in our kind of public health infrastructure.
Yes, we wrote a report called the Healthcare Inequality Index that measured the distribution of healthcare services across the United States by health service area and the ability of people to afford those services in the corresponding jurisdiction, which highlighted a lot of the problems you just mentioned. And we have a number of medical deserts across the United States where there are no services available, which kind of ties back to the Flexner report, because as physicians of color have left their neighborhoods, when they become affluent, they don't return to their neighborhoods frequently. And so the clinics that were run by Black doctors or doctors of color, one way or another, have gone away. The physicians retire and they don't get replaced. And so we have that problem as well. But in addition to that, it's things like zoning issues, right? So because frequently in more impoverished areas, we have zoning that allows for more industry, more commercial activity, which means that the quality of the air is worse. We have fewer parks, people can walk around. And I wrote a report earlier this year, which was really, really interesting, at least for me anyway, that highlighted some of the problems of Southern Dallas. Southern Dallas comprises 60% of the land mass of Dallas County. And one of the things we discovered was there's not a single strand of fiber optic cable. So that means that people don't have...
Telecom companies have never set it up down there.
Correct. Now you can ride the backs of DSL carriers through cable and other, but your quality of internet access and the speed of transfers is so slow that it's a problem. So and in fact, the people who talk about the social determinants of health really focus on access to the web as a super determinant of health. So if you don't have access to the web, which is kind of one of the issues that's been talked about in terms of rural access, but it can also be fairly urban access. I mean, Southern Dallas is not far from downtown Dallas. It's part of a 6 million person SMSA. It's a big place.
Yeah, and so talk to me about where you think that fits. I mean, we need to. Is it going to be government programs? Is it going to be kind of a way that the healthcare system is redesigned? How do we get these services to the right people in the right form?
Well, I think it's going to be a tapestry, and hopefully technology will help us. Let me give an example. There was an experiment done by a school in Southern Dallas, and they said they start here on our campus and use public transportation to get a today's copy of the New York Times. Do you know how long it took them? 2 hours.
Yeah.
2 hours using public transportation to get a current copy of the newspaper. A friend of mine once said that the bulwark of
How long does it take to get a six-pack? Probably like 5 minutes.
You didn't need to get on a bus or a train, you could walk.
Yeah.
The problem that you have, though, in addition to that is, as a friend mentioned, the bulwark for access of the transportation bulwark for access to your healthcare provider is church vans in Southern Dallas. In other words, the church community gets people to their doctor's appointments by riding on and scheduling on a church van. So when you think about it, it's got to be this tapestry. I mean, we look forward to the day when something like a Facebook portal can be placed in the home of an elderly person and they can just tap on the screen and automatically connect with their doctor. That'd be a great solution. Technologically, it's available right now. From a cost perspective, it's available very low cost. But there's so many regulatory, when I use the term regulatory, I'm not only talking about government regulations, I'm also talking about commercial regulations, meaning the rules that are dictated by the insurance companies on the healthcare systems to do or not do something in particular.
Yeah.
So this.
Yeah. So if we can get a tapestry approach and they get a ride to see the doctor through a church van, as long as they get the service they need, that's sufficient. It's maybe not ideal, but it's sufficient.
It could be, yes, but I mean, think about how much better it would be if you could simply double tap on your Facebook portal or your smartphone and see the doctor. Most of the time, or frequently, I would say, you don't actually have to see the doctor in person. You're there to describe the problem, see the doctor, face to face, and get a prescription, or have a care plan developed for you.
Yeah, interesting. Okay, so talk to me about your view of where the health systems go. I mean, I'm fearful, but I want to get your sense of, there's going to be pretty massive consolidation, pretty massive changes in the health systems. A lot of these trends are going to impact them. But at the same time, they are the center of the way we deliver value. So even if you build around it, they still are. When you're going to get triple bypass heart surgery, you're in the hospital, right? So how do you think that evolves over time? Like, do health systems continue to be the center and we build around them, or does it fracture and it gets all kind of rethought?
Well, I think that ultimately they're going to have to distribute in a lower cost fashion. But the strange thing is that there's actually nobody in the healthcare industry that's genuinely interested in reducing the cost of healthcare.
Yeah, right. They make less money if they do that.
Yeah, they do. And so what I'm hopeful is that we can use consumerism, to one of your earlier points, to drive that in a better way. So let's imagine that we had broader adoptions of HSAs and we paid for our services out of the HSA funds that we had accumulated. And then we had direct visibility into both the service offering. We had privity of contract with that provider. And the provider wasn't concerned about any bifurcation of his or her loyalties. Because right now we have that, right? Is the provider loyal to the person, to the entity paying them, the insurance company, or are they loyal to the patient? Well, the answer
they're literally called the payer by everyone. So, are they loyal to the payer or are they loyal to the patient? Right.
And so that's a problem, and we haven't reconciled that. And as as everybody is familiar with this, the fact that the growth in insurance adoption really came since World War II under the Revenue Stabilization Act that was passed under FDR, arguably for some good reasons. But what's happened now is that adoption of insurance has caused a disintermediation between the patient and the provider, because now you've got payer, patient, and provider. And so until we get that solved, I don't think we're going to be able to really solve the broader problem of cost. Because again, you probably know this, Vic, but in 31 states, the way that insurance premiums are dictated is by the state government. There are no market forces per se that are working there. The insurance company goes to the state Department of Insurance and says, hey, my costs went up. And the State Department of Insurance says, looks like they have. And then the premium goes up. I mean, that's a gross oversimplification, but it's broadly the way things work.
Yeah, and so the areas that I'm looking to from a constructive point of view are where there are big pools of money that could decide to push for change. And so that is Medicare Advantage, Medicare in general, but Medicare Advantage, managed Medicaid, or large employers who have enough buying power that they might decide to push for change. That, to me, those are the potential places where they could lead and really try to just kind of realign incentive structures, right? So that it is not volume or value, which is the traditional debate, but let's realign incentives so that as a large employer benefits, the health system benefits too, or as the government benefits, the health system benefits. The patients then would be taken care of because the incentives are aligned, where today I'm not sure that's true.
Well, here's the challenge. First of all, I think there is room for plenty of optimism, and here's where it's going to come from. It's going to come from small and mid-sized businesses who are actually funding their own healthcare. And that's really the silver lining, because they do have an interest in reducing the cost of healthcare by creating self-insured pools and then driving those costs down. There are companies out there doing that today.
So you think small and medium are going to be more impactful than the large ones?
Absolutely. Absolutely. Because the large companies are more immune to the cost pressures one way or another. And typically CEOs don't want to, and CFOs don't ever want to think about the true cost of benefits. It's funny because we have all this great talent spread across the executive ranks, but usually the strongest talent in the organization is not the person running benefits or the person running HR. And that just tends to be the case. I'm not saying bad things about HR. I'm just saying that just tends to be the reality of the situation. And nobody really digs into the issue of the cost of healthcare. And a few large companies are really digging into how to make that cost go down. So what's happening is that small and mid-sized companies, and small and mid-sized meaning, probably up to $500 million in annual revenues, those corporations are really going to make the difference, because they can.
Maybe they're small enough to really care and really need to focus on it, but they're also big enough to be able to talk to a hospital system and drive change.
That's correct. And the other issue is that organizations of that size tend to be a little bit more geographically concentrated than other organizations. So if you're ExxonMobil, you've got people all over the planet, and you need a care package, a benefits package that's going to address that issue. If you're Texas Instruments, you've got people all over the United States. If you're Bluebell Ice Cream, or if you're a smaller firm which is largely in one or two or three or a few states, then you have more coverage available to you and more bargaining power with the coverage. Again, at the end of the day, if you're an insurance company, if you're a payer, what you're really looking for is ubiquity of coverage, right? You want to make sure that if one of your employees needs care, they can get it in the geography where they live. You don't want them having to try and figure that out.
Yeah. Okay. So you've been working on this for a long time. You started at EDS and then consulting, now private equity. Talk to me about what you wish you knew at the beginning of your career. What have you learned that if you could go back to your former self, you would have preferred to know then?
Boy, that's a big question. I wish that we all had a chance for a big do-over like that.
Yeah.
I think that one of the things that I would point to is we never understand the complexity of the things we're getting into. In one sense, thank goodness we don't, because we never endeavor to.
We wouldn't get out of bed in the morning if we.
Exactly. On the other hand, I think that as I get older, the thing that I have to adjust constantly is my expectation around time. How much time is it going to take to solve a problem? Where can I be effective? How can I apply my resources, my time and treasure to help move the needle in one place or another? And can I achieve that in a responsible time frame? Because some of these things, you think about it, one of the things most people don't realize is, do you know how long we've been having the conversation around healthcare in the United States?
Probably since 65, maybe earlier. I don't know.
John Adams, as in the president.
Yeah.
He was the first one to charge sailors for healthcare because they were coming back with diseases. So he charged them a certain amount per month when they were in the United States. So it's basically since the beginning of the country. So this is not a new topic. I think you got a lot of traction really in when Social Security was passed and then ultimately in 1965. And it grew traction again in the middle 80s. And then when the Clintons got involved, I think they drew a lot of attention to it as well. But we have this big conflict of interest in the question itself, when I think it really goes back to the moral question presented earlier in the conversation, which is, hey, we've got to get comfortable with the fact that either it is or is not okay to make money in healthcare. Yeah. Right now, I don't know if you know this, but the profession that comprises the greatest percentage of the 1% is healthcare.
Yeah. So I think that's really thoughtfully said. I guess the thing that strikes me is at the same time, GTC is shifting towards investing in healthcare because it's a generational opportunity. And so what I see, and I want to get your thoughts, is that the boomer generation is, a huge percent of the population, and they're moving into a stage of life where they're going to need a lot of healthcare. Just as the body ages, you naturally need to get more healthcare. And my view is that we must solve this because we can't afford not to. We have to figure it out. And I agree with you completely. There's going to be a huge opportunity to invest in the innovations and the people and the companies that are making positive change. And even if they're not perfect, making a positive change, will be very successful and be a great place to be. Does that fit with what you think?
Absolutely. And so we've created a couple of things. We're using our healthcare inequality index to map out where we can invest geographically. So we've identified, for example, 207 acutely underserved markets.
Yeah.
Okay. So we've got a place to look, and those markets are populated with between 150 and 300,000 people per market.
Yeah.
So that's
it's a healthcare desert. You can bring services to that desert, and there's lots of people that need help.
That's correct. So hopefully we can move the needle there. Our Center for Impact Indices, I think, also will be helpful because we want to start creating indices that can measure the impact of investments made with the purpose of solving a social problem. So, for example, you correctly pointed out earlier this issue around food. We have the same problem with water quality. It's not so long ago that we had the big issue up in Flint, Michigan with bad water. We have the same issue with sanitation. We have the same issue with air quality. So these things all don't operate in silos. Sometimes there's a lot of overlap, but I think that there's an opportunity and there's a desire in the marketplace, in the investor community, to apply some of their capital to help solve some of these problems, and also to get proper returns, to get market-based returns for their investment. So I think we have to come about it from that perspective.
Yeah, particularly if you have an index or there's a measurement tool where I can say, I'm going to get a good result financially, and also I can see this quantitative measure move in a positive direction. It's kind of a win-win. I'm making impact and I'm making return, and it's great for both sides.
Yes, and I think that's the opportunity for the new generation of millennials to come in and really make a significant impact for good, because their hearts and minds are really anchored in this proposition. They want to move the needle in a positive direction. I think we can do that, but I think it's going to take us all to come together and to rally around solutions and change laws to allow those solutions to really be effective in their implementation.
Yeah, I agree. So talk to me about how you stay current on all of these topics. I mean, we've mentioned a bunch of topics. How do you keep up with it? Are there certain things you read or things that you follow that the audience should think through?
Well, I think there are a variety of sources. I'm a pretty voracious reader, as you might have observed. I'm writing a couple of books right now, one on healthcare reform that is hopefully going to get out this fall. And so I'm always searching for the current topics. I'm also the guy who buries into the report that was referenced. So I mentioned the Bureau of Economic.
In the newspaper or magazine, they reference a report, and then you'll dive in and read the 400 pages.
Yeah, I'm that guy. Unfortunately, I'm that guy, which means that I'm the worst guy to be seated next to at a cocktail or in a dinner party, right? Because I can want to talk about things well beyond the point that I should. So for me, it's just a question of having a big curiosity and really an appetite for learning.
Yeah. So tell me where, if people want to search for the reports you've mentioned or check out some of the work your firm has done, is there a website that they can go to read some of this stuff?
There is, and what I can do is I can give you a link, Vic, so that your viewers can link to it in a very easy fashion.
Yeah. Okay. Great. Well, Todd, thanks for doing this. I really appreciate it. Thanks for taking time in these crazy times to fit it in. It's been great. I really appreciate it.
Well, I appreciate it. I think the work you're doing and these podcasts are actually very important. I'm hopeful that they're going to get seen and listened to by the right people in the right circumstances and the right positions of authority to help make a dent. Because I think what you're trying to address right now is critical to our nation.
Yeah, great. Well, I think all we can do is put it out there, and I think it'll get passed around, and the right people will see it. So.
Let's hope so.
All right. Thanks, Todd. Appreciate it.
Thanks once again.